The sensation of nausea is pretty complex, but our approach to treating it doesn't have to be a mystery. In this video, we will be looking at the different medications used to provide relief for the different causes of nausea. We're going to break down how and why these medications work. And I'm going to clarify one of the biggest misunderstandings I encounter as a palliative care doctor. Let's talk about it. Welcome to Palliative Care Explained, a channel aimed at answering your questions about palliative care. My name is Dr. Jonathan Wong, and I'm a palliative care doctor based out of Winnipeg, Canada. Please see the welcome video of this channel for my declaration that I do not have any conflicts of interest or any financial sponsors, and for the medical legal disclaimer statements. I will leave a link in the description box below. If you haven't seen parts 1 and 2 of the series, where I discuss the different causes of nausea and the non-pharmacological treatment strategies, I will also leave links for those in the description box below. But in this video, I will be discussing the different types of medications that we can use to relieve the sensation of nausea. I'm told that there are many different anti-nauseants to choose from. How do you decide which one to use? As we learned in part 1, the different sources or causes of nausea use different neurotransmitters to activate the vomiting center. Here's the depiction. Specific neurotransmitters can bind to receptors in the vomiting center, and if activated, the result is nausea. When choosing an anti-nauseant, your medical team tries to pick the one that blocks the main neurotransmitter involved in that particular cause of nausea. And by blocking the receptor, the neurotransmitter is then unable to activate it. This concept also explains why certain anti-nauseants work better for some types of nausea, but less well for other types. So let's start with a common cause of nausea, motion sickness. Signals from our eyes and our inner ear are interpreted within the vestibular system, which can then activate the vomiting center through the neurotransmitters histamine and acetylcholine. With motion sickness, medicines that block the activity of histamine and acetylcholine at the vomiting center would be the ones more likely to provide relief. So one of the most common over-the-counter histamine blockers is dimenhydrinate, often sold under the brand name Gravol. This is only one example of many antihistamines that can be used for nausea caused by the vestibular system. And now you know why it works. What about medicines that block acetylcholine? You may have heard of scopolamine patches or hyoscine patches being used for motion sickness. These anticholinergic medications relieve nausea by blocking acetylcholine receptors in the vomiting center. Scopolamine patches, however, have run into production shortages, and these have become very difficult to find in Canada. Unfortunately, antihistamines and anticholinergic medications have many shared side effects. The most common ones are sedation, sleepiness, increased confusion, dry mouth, dry eyes, and more difficulty passing urine. Sedation and increased confusion are particularly troublesome side effects in older patients. As such, we often suggest avoiding these altogether or using low dosages where possible. The next source of nausea to discuss is the gastrointestinal tract. The main transmitters involved in this nausea pathway are dopamine and serotonin. Delayed stomach or gastric emptying is a common cause of GI tract-related nausea. Domperidone is often used in this setting, as it blocks the effect of dopamine in the gut. This allows the stomach muscles to contract more, helping to propel food along. It also has a role in blocking dopamine at the chemoreceptor trigger zone, further decreasing the sensation of nausea. Metoclopramide is another medication frequently prescribed for nausea. And similar to domperidone, It also blocks the effect of dopamine, giving it a pro-motility effect. At higher dosages, it also works to block the effect of serotonin, further helping with nausea relief. Sounds like these two medications are pretty similar. How are they different? Indeed, Domperidone and metoclopramide are similar in terms of function, and both are frequently used as first-line options for mild to moderate GI tract-related nausea. However, metoclopramide can easily cross through the blood-brain barrier, and in some patients, this can result in central nervous system side effects, such as restlessness or movements resembling Parkinson's disease, such as muscle tremors and rigidity. In contrast, domperidone does not cross the blood-brain barrier, so it can be used in patients who experience these unwanted side effects. Now, if these first-line medications are inadequate for nausea relief, medical teams often then recommend medications such as haloperidol or olanzapine, both of which are very effective at blocking the effects of dopamine. But the use of these medications is a source of great confusion and misunderstanding. What makes this confusing? You see, haloperidol and olanzapine are both antipsychotic medications. Whoa. I have nausea, but I'm not psychotic. Why are you using antipsychotic medications? And this is exactly the problem. Through their depiction in movies and television shows, antipsychotic medications developed a bad reputation. Let me explain. Patients on psychiatric wards are often portrayed to be overly sedated and unresponsive, often described as looking stoned, zombified, or spaced out. These catatonic states can indeed be the result of antipsychotic medications being used at high dosages. And in the context of acute psychotic episodes, sometimes there is no option but to use higher dosages. Why do people look spaced out? Neurotransmitters, such as dopamine, have multiple functions in our bodies. In the context of psychotic illnesses, there is often too much dopamine activity in the brain. Antipsychotic medications are used to help decrease that activity. To address the common misunderstanding as it relates to nausea relief, medical teams often use low dosages of antipsychotic medications because of how it works. They block the action of dopamine at the vomiting center and in the gut. The dosages used to relieve nausea are typically a small fraction of what is used in acute psychiatric illnesses. Haloperidol is a relatively older medication, and it falls under the category of typical antipsychotic medications. It is also useful in that it is available in oral tablets, liquid forms, as well as injectable forms for those unable to swallow. But as with all medications, there can be side effects. As discussed earlier, neurotransmitters such as dopamine have many different functions in the body. By attempting to block the activity of dopamine, we can also inadvertently affect the other functions of dopamine. And in some patients, we can observe movement-related side effects, such as Parkinson's-like features or uncontrolled muscle movements, even at lower dosages. So, in an attempt to reduce these neurological side effects, newer antipsychotic medications, such as olanzapine, were developed. Olanzapine falls under the atypical class of antipsychotic medications, and they generally have fewer neurological side effects compared to the older typical ones. Furthermore, olanzapine also has a blocking effect of serotonin, in addition to its effect on blocking dopamine. And this property has made olanzapine widely used for treating chemotherapy-induced nausea, as well as treating nausea in the context of palliative care. In Canada, olanzapine comes in tablet form, as well as a disintegrating or dissolvable tablet, and the latter may be very useful in those patients less able to swallow. Now, there are scenarios where antipsychotic medications should be avoided or used with caution, such as in patients with Parkinson's disease or in those with Lewy body dementia. So I encourage you to openly discuss with your medical team whether these medications can be safely used in your specific circumstances. I hope this discussion clarifies the use of antipsychotic medications for nausea. It is not just used in psychiatric illnesses. With lower dosages, they can work really well to treat the sensation of nausea. Are there medications that specifically block the action of serotonin? Yes. The commonly used medications are Ondansetron and Granisetron. These can block the action of serotonin where the vagus nerve meets the gut, as well as having a blocking effect at the vomiting center. The most common side effects, however, are headache, dizziness, and ironically, constipation, which itself can be a cause of nausea. Both of these medications are also available in dissolvable oral tablet forms and injectable forms, making them useful for those patients who are less able to swallow pills. These serotonin blocking medications are very effective for chemotherapy-induced nausea and vomiting. However, evidence-based guidelines specific to palliative care do not recommend these to be used routinely as first-line treatments for nausea. They can be used if other first-line anti-nauseants are ineffective, though. Are there other neurotransmitters we should talk about? There is a relatively new kid on the block, and that's the neurotransmitter substance P and its receptor NK1. And this has become the target for a newer generation of anti-nauseants. NK1 receptor blockers can be used in preventing and treating chemotherapy-induced nausea. However, medication availability and coverage varies greatly depending on where you live. And there is also forecasted to be medication discontinuations in the near future. So please speak to your medical team regarding what options are still available and whether or not it is right for your specific needs. Furthermore, its specific role and effectiveness in treating nausea in the context of palliative care requires further study. As such, at time of filming, this type of medication is not widely used. What about the swelling and stretching of organ linings you spoke about in part 1? What can be used for that? Corticosteroid medications, such as Dexamethasone, are commonly used to help relieve nausea due to its potent anti-inflammatory properties. This may help decrease the size and the amount of swelling around cancers, thereby lessening the pressure placed on adjacent tissues. For the same reason, Dexamethasone is also frequently used to treat nausea caused by increased intracranial pressures, such as that caused by masses within the brain. It is also commonly prescribed alongside other anti-nauseants for chemotherapy-induced nausea, making it a widely used and very useful medication in this setting. What about cannabis? I've heard it can be useful to treat nausea. Yes, indeed, but they work on a different set of receptors than what we have already discussed. THC, or tetrahydrocannabinol, works as an anti-nauseant by binding onto and activating the CB1 receptors in the brainstem. These CB1 receptors are located near the chemoreceptor trigger zone, and their activation likely has an influence on decreasing activity in the vomiting center. THC, as well as CBD, or cannabidiol, can also have an effect on serotonin receptors. And this explains why THC and CBD has found a role in treating chemotherapy-induced nausea, alongside other anti-nauseants. THC and CBD likely also influence the CB1 receptors at the level of the gut, further decreasing the sensation of nausea. The use of cannabis in the context of palliative care is a growing field of study and has gained more public acceptance. I hope to make a video dedicated to the use of cannabinoids in palliative care. Please stay tuned. I encourage you to speak to your medical team about whether the use of cannabis is right for your specific circumstances. What about in cases where we've tried all the things you've already mentioned, yet I'm still feeling nauseated? What then? This is a common scenario, especially in the context of end-of-life care. In these scenarios, we often prescribe what can be thought of as broad-spectrum anti-nauseants, ones that block multiple different receptors all at once. The medications used vary depending on where you live, but common examples of these broad-spectrum anti-nauseants include Methotrimeprazine and prochlorperazine, both of which are classified as typical antipsychotics. These target several different subtypes of dopamine, serotonin, histamine, and acetylcholine receptors all at once. These medications have a role in patients where nausea is caused by several simultaneous causes, or in patients where severe nausea has not adequately responded to other more targeted medications and interventions. Due to the multiple subtypes of receptors being blocked, the side effects will also be more prominent, with sedation or sleepiness being very common. So before using these, I encourage open communication between you and your medical team. Treating nausea can be really challenging at times, and for some patients, they need several different medications to keep things controlled. And sometimes, despite our best efforts, we still need to offer an admission to hospital for injectable or intravenous anti-nauseants to ensure that the medicine is fully absorbed into the body. Because if the medicine can't stay in, can't help. Are there medications we can use to treat anticipatory nausea? Yes, there are. But I first want to emphasize that anticipatory nausea is a conditioned behavioral response to certain triggers, such as receiving chemotherapy. In part 2, we discussed several non-pharmacological treatments, such as relaxation techniques, mindfulness, and cognitive behavioral therapy that can help break the cycle. However, in some patients, non-pharmacological treatments may not be enough. In those cases, the use of anti-anxiety medications, such as lorazepam, may be effective. Ideally, although much easier said than done, it is best to prevent the development of anticipatory nausea by controlling nausea from the get-go of chemotherapy treatments with a combination of non-pharmacological strategies and the appropriate medications, thereby preventing the cycle from even starting. In summary, nausea is complex, but our approach to treating it doesn't have to be a mystery. By understanding the specific pathways and neurotransmitters at play, your medical team can recommend a targeted plan that is more likely to work. I also hope this video clarifies a common misunderstanding about the use of low-dose antipsychotic medications in the treatment of nausea. As always, I encourage you to ask your medical team about why any treatment or medication was chosen. It can alleviate your stress and can clarify any misunderstandings that you may have. I hope to see you for the next video topics. Thank you very much for watching this series.